From Canada, Citizens Forum, where we look at the important issues of the day through a lens of democracy and media and try to figure out, how do we build a better country for ourselves? Hello, welcome to From Canada Citizens Forum. It is Saturday, April the 19th, 2025. My name is Jack Etkin. My guest in this segment is Corey Ranger, and we're going to be talking about what is generally known, I guess, as the toxic drug and death crisis. Corey is with a group called the Harm Reduction Nurses Association. And Corey, maybe you can start by just telling us a bit about yourself and how you got involved.
Yeah, thank you so much for inviting me to your show. My name is Corey. I use he, him pronouns, and I'm a registered nurse. I reside on unceded Cowichan tribe territory in what is colonially referred to as Duncan. And I have spent the last 12 years working on the front lines of Canada's drug poisoning emergency. I've been a street outreach nurse in downtown Edmonton, working with people who are experiencing homelessness, who are living with HIV or hepatitis C or co-infected, and are experiencing significant barriers to care. I've worked in Calgary, Medicine Hat, and now back in British Columbia, supporting the scale up of supervised consumption services, naloxone programming, and prescribed alternative programs. The Harm Reduction Nurses Association is a Canadian national organization of nurses who work in or support harm reduction approaches to healthcare. We do a range of activities, including supporting Canada's first harm reduction course through the University of Victoria, to developing scholarships for nurses who work in harm reduction, who want to continue their education. And we also partner with national and regional advocacy groups, including Mom Stop the Harm, the Canadian Drug Policy Coalition, to support the development of policies that promote equity and to challenge laws and policies that cause harm.
Right. So, I mean, I think everybody knows that this is a disaster that's happening in British Columbia, where we are, and across Canada. Can you just very briefly, because I don't know them, what are the numbers of deaths?
Yeah, I think it would, be more aptly referred to as an emergency, because here in British Columbia, we have a declared public health emergency over fatal drug poisoning deaths. On April 14th, 2016, Provincial Health Officer Dr. Perry Kendall and the then Minister of Health, Terry Lake, declared a public health emergency over overdose. And the number of deaths in 2016 was just shy of 1,000. 997 people died in BC in 2016. And that was the threshold to say, this is not normal. Something really urgent is going on here. So they declared a public health emergency. We have now entered into the 10th year of that declared public health emergency. Just last week, we were at the 9-year mark. And in that time, over 16,000 British Columbians have died by fatal drug poisoning. 152 just in January of this year alone. In British Columbia, it is the leading cause of death for people aged 10 to 59. It amounts for more death than motor vehicle collisions, suicides, and homicides combined. And in Canada, more broadly, since January of 2016, at least 50,000 Canadians have died preventable deaths.
And yet it just goes on and on and gets worse. So what is causing, big picture, what's causing the deaths?
Yeah, it's really important that we have this conversation, because we actually know some of these answers. It's not a mystery. And a lot of the data that I'm going to be sharing today is publicly accessible data. You can go on to the BC Coroner's website. You can go and access the reports and all of the evidence that's been generated about this crisis. And so we know what's driving this emergency. We know that it is a toxic, unregulated supply that is killing people en masse. In 2016, about 67% of all drug poisoning deaths were linked to fentanyl. In postmortem toxicology, fentanyl was showing up 67% of the time. By 2018, it was up to 86%. In today's current iteration of the drug poisoning emergency, we're actually seeing more and more adulterants and unwanted contaminants in the unregulated drug supply. And so it is not just fentanyl anymore. It is different synthetic analogs of fentanyl. It is also non-opioid sedatives like benzodiazepines, animal tranquilizers. This toxic soup has no quality control. It has no predictability. And so for people who are compelled to access this supply of drugs, who don't have a regulated supply to access, they are essentially rolling the dice every single time because they don't know what the purity of the drugs are. They don't know what adulterants are in it this time. They don't know how it's going to affect them. And that's why we're seeing such a distressing image play out in our public eye. We're seeing people unconscious and incapacitated for hours on end. And that is because the drug supply is poisoned. There is no predictability or agency of choice for people. And when you combine opioids with other non-opioid sedatives, people are sedated for extremely long periods of time. They experience amnesia. They're subject to violence. So, we actually know this. We've seen this trend play out since the declaration of a public health emergency. We know that the drivers of this crisis are unregulated drugs. We know that some people might have a substance use disorder, might have an addiction, but we also know that there's a lot of people who use drugs recreationally, episodically, and they're also dying by drug poisoning death. There's an image that we have of like who's most affected by this crisis, but this crisis actually cuts a clean swath through every demographic, every socioeconomic status. You'd be very hard pressed to find someone who hasn't been affected by it in some way, shape, or form.
And why are these adulterants added? Is it to make it cheaper for the drug gangs, whoever they are the ones behind the unregulated supply? Is it just cheaper for them? They have no concern about killing their clients? Is that what it is?
Well, it's not necessarily a very good business model to kill your clients. And so it's not that people are always intentionally doing this. A lot of times what we're seeing is drug supply evolutions happen because of changes in demand from the population, because of changes in availability of precursors. And for the most part, why we see drug supplies evolve and continue to get more toxic, more concentrated, more potent, is because of criminalization. So we have a legal regulated supply of alcohol where you can go to a liquor store and you can determine how much, what percentage alcohol is in it. You can be guaranteed that your alcohol doesn't accidentally contain fentanyl. We don't have that for some other drugs. Okay. And in fact, when we criminalize drugs, what we know from studies who have looked at the iron law of prohibition is that the harder we enforce, we actually incentivize and create more toxic versions, because fentanyl is easy to ship. It's small, it's discreet, it's potent in small amounts. That is a response to criminalization. That is drug manufacturers innovating in order to continue to meet the demand.
So to me, as this thing evolved, to me, safe supply was the clear way to go. That's what I thought. And, I know very, very little about it, but I always thought safe supply was the way to go. And yet that idea has been, it's been almost contaminated in the minds of lots and lots and lots of people. And part of that, I think, is the media, because the media is always focusing on the negatives of it, almost as if trying to keep safe supply out of the game, which only benefits the drug gangs, as far as I can see. So how you wanted to talk about the role of information, misinformation, and disinformation. So maybe you can go into that.
Yeah, I have significant experience in working in and supporting prescribed alternatives programming, or as you've referred to it, as safer supply. And we know a lot about these programs already as well, even since their earliest inception, before the global pandemic occurred. There were pockets of programs that were already in operation, and then since 2020, there's been a significant increase in the number of programs that offer prescribed alternatives, and there's also been a significant increase in the number of studies that are being done on these interventions. In fact, I just did my homework for this segment today, and there are at least 106 peer-reviewed studies, evaluations, scoping reviews, and commentaries on prescribed alternatives. And the bulk of those reviews and studies and scoping reviews have demonstrated that prescribed alternatives reduces an individual's risk of fatal drug poisoning, that it increases an individual's access to health and social services, that it improves overall functioning and stability in people. There's studies that have even shown that it increases someone's likelihood to be retained on traditional addiction medicine treatment like methadone, Suboxone, or Orcadian. And so there's a fundamental disconnect when we see this huge body of evidence that's pointing us towards this promising practice, and yet significant pushback. And a lot of that has been driven by misinformation, disinformation, and moral panic. And it's not new to safe supply or to harm reduction. We've seen the same moral panic, around naloxone programming. Take-home naloxone programs are probably been the single greatest intervention in reducing risk for drug poisonings across the country. And yet when those programs were rolled out, there were people who were talking about naloxone is going to enable people to use drugs unsafely. And so this ongoing moralizing of substance use and the willingness to undermine and discredit the evidence supporting these interventions is largely driven by moral entrepreneurs, by media personalities, by people with a lot of power and a lot of investment in seeing these programs fail. And so this is one of the very few facets of healthcare or medicine where someone with no experience can just show up and decide to make a claim and to be taken seriously about it. We don't hear people making those claims about appendectomies. We don't hear people making those claims about blood pressure medications, but we do hear people talking about it a lot when we enter into the realm of substance use.
Yeah. I think a lot of in my mind, and maybe I'm completely wrong, but a lot of the pushback, I think, comes especially from people in lower income neighborhoods, because they often correctly fear that their lives are going to be disrupted by a clinic that gets set up in their neighborhood, right? And to me, that is a very, very, very valid concern. But that's only the homeless population who would be there is only a small part of this problem. The vast majority of the problem is befalls people who lead very regular, normal lives. They're not homeless. So is there a solution? How do you make it so that people, because I think that's the pushback is from people in lower income neighborhoods who feel and correctly, how do you solve that problem?
Well, I think I'll go back first just to.
And maybe I'm wrong. Maybe I'm wrong in what I'm even saying. I don't know.
It's certainly worth discussion. I think, just to revert back to one of your comments, yeah, we do know that the majority of drug poisoning deaths are occurring in people's residences. We do actually know that the single most affected demographic is young men age 30 to 59 who live alone, who likely work in the trades, and they need access to harm reduction
So
intervention.
safe supply could just be mailed to them, right? I mean, they could just get it in the mail. So there's no problem from all of those people, which make up the vast majority. And then I think if you put the money into the distributing safe supply on the streets, you can at least really minimize the problem to the neighbors and whatever.
I think there's a fundamental misunderstanding that these programs that they cause social problems. And so the framing of the narrative of, people being resistant to these services being established in their neighborhood because they're worried about the unintended consequences of having visible poverty near them is a result of incrementalism. We need those services and we need those clinics, but we need to get people housed. We need to improve the material conditions of everyone so that they're not left braving the elements outside of the clinic and then causing concern for the neighbors. When we just do the bare minimum and establish a life-saving service, but we don't help rise the tide and lift all the boats, then people will continue to experience harms, and it'll continue to play out in the public eye because there's nowhere else for them to go. And so, channel that frustration and say, like, well, if we don't want people outside, then let's get them housed. Yeah. Let's address our housing and affordability crisis. We can do all things. We can make everybody feel safe. We just need to do the full job. And right now we see piecemeal policy. We see little bits of pilot programs, precariously funded initiatives. And that's insignificant in comparison to the really serious, complex social problems we have right now.
There's been a lot of media coverage of the thought that if you give safe supply, as was tried, from what I understand, then it all ends up being pushed into the market or in some way. So that's a negative too. Can you comment on that?
I think the narrative around diversion has been very disproportionate in comparison to what we actually know about the drivers of the drug poisoning emergency and who is accessing and how many people are able to access safe supply. At its peak, there was about 5,000 British Columbians who were accessing prescribed alternatives, according to the BC government. And that is in comparison to the estimated 225,000 British Columbians who use unregulated drugs in any given year. And so even when the most amount of people were accessing this intervention, we were talking about 2 to 3% accessibility rate. And if you look at the data from BC coroners and you look at what's killing people, the drugs that are most closely related to prescribed alternatives are somewhere in like the 3% range, whereas fentanyl and fentanyl analogs and benzodiazepines are killing people in droves. And so we don't see the media talking about fentanyl very often, unless it's Donald Trump talking about borders and tariffs. We don't see people talking about the benzodiazepines. We don't see people talking about the animal tranquilizers that are causing horrific wounds on the streets. We hear a lot of obsession about safe supply, and that's because there's political appeal. It gained a significant amount of traction during the BC election. We saw politicians essentially campaigning to end harm reduction and to end safe supply programs. Same too with the attack on decriminalization. It got traction. People were listening. And a lot of times with misinformation and disinformation, to really create an effective moral panic out of misinformation and disinformation, you need to wrap it in some truths. And what's true, what people are seeing on the streets is that things are not normal. We shouldn't be seeing this many people suffering outside. We shouldn't be seeing people unconscious for that long. That's very distressing. Those are real emotions that everybody's experiencing when we look outside our doors and we see people struggling. We see our neighbors struggling. But then we're told to believe that it's the fault of decriminalization or the fault of safe supply, when these are decades-long problems that have been emerging and festering for a very long time. Decriminalization lasted for 1.5 years. Safe supply has been around for 4 years, 5 years tops. What are we talking about? We've got a housing crisis where we've seen year over year more and more people on the streets. That does not get solved through blaming safe supply or harm reduction, nor has that been caused by those interventions. We need to think bigger and hold our politicians to account and ask them to really, how is this policy solution going to stop the deaths? How is this policy solution going to get people housed?
I don't remember a lot about the decriminalization process, but I know that some time ago, the BC NDP government basically, because there's a lot of public support for safe supply and that kind of thing, so they took one small step in that direction, which was to decriminalize small amounts of drugs, whatever that means. And so that was done by our government here in BC. And then shortly thereafter, there was a huge explosion of stories in the media talking about how this thing that the government had done was causing havoc in our hospitals. Nurses were getting beaten up. Patients were being, disturbed. Lots of bad things were happening. That's what we were told. And so almost immediately, the government backed away from that program, which again was a small step in what I consider to be the right direction, but they couldn't. And so, talking about misinformation and disinformation, did the media tell us the truth about what was actually happening or not?
I would say absolutely not. We can look at decriminalization as a case study on policy implementation failure and policy communication failure as well. What decriminalization was intended to do was to mitigate the harms of criminalization, and criminalization drives drug supply volatility. It increases someone's likelihood of being incarcerated. It disproportionately impacts Black and Indigenous people here in Canada. It reduces your likelihood of being employed. It increases your likelihood of being deported. It causes a whole host of problems, including increasing someone's risk of dying, because when you are at risk of criminalization, you conceal your use. You isolate so that you cannot be found. And that's why we have people being found in parkades and alleyways because they used a loan, because they were likely hiding from being potentially criminalized. And so decriminalization was intended to reduce those harms. Decriminalization alone doesn't change the drug supply. And so there's a problem here when decriminalization is implemented, especially in the way that it was in British Columbia, where it was not informed by people with lived and living experience. So we know in policy that the people who are most affected by the policy need to be consulted, need to be part of planning. Otherwise, it doesn't usually go well. That didn't happen. It was for a limited amount of substances. It was for a limited threshold of substances. A lot of it was driven by policing and by a lack of actual knowledge of drug use culture. And then it wasn't coupled with meaningful transformative changes like addressing the housing crisis, like addressing the unregulated drug supply. And so you decriminalize one end of it, which, helps people stay in hospital for longer, helps people avoid being incarcerated. But they didn't do the other part of it, which is a still criminal supply.
So did the decriminalization actually lead to bad outcomes? Because I never saw the connection, except that it blew up in the media, but maybe I'm wrong.
There hasn't been evidence to date that has shown negative outcomes associated with decriminalization, and there were early outcomes demonstrating positive impacts, like a reduction in the amount of people arrested and incarcerated. What we do see, though, as I've already said, is like we have more and more people who are visibly impoverished. We have more and more people who are outside, and so there are more people who are seeing folks using drugs outside. And in the context of a poison drug supply, where one wrong dose, one bad batch could be deadly, using in a public setting is a protective mechanism, because there's a higher likelihood that someone's going to find you and reverse that overdose. If you think about, someone in a park and they're smoking a cigarette, and you say, "Hey, sir, you can't smoke here," and they go, "Okay, fine," and they go and smoke in an alleyway, they're likely going to walk out of that alleyway. And if someone is using unregulated drugs and you say you can't do that here, and then they go and use their unregulated drugs in an alleyway, they're probably not coming out of there, because the unregulated drug supply is unforgiving. And because if you use alone, isolation plus an unregulated drug supply is a recipe for death.
And yet we're a million miles away from a safe supply.
We're actually going further back from a safe supply in real time. There is significant policy regression, and it's at the heels of moral panic. If we can talk about all the evidence, if we can say we've got decades of evidence supporting harm reduction, systematic reviews, scoping reviews telling us that these interventions work, and yet we're seeing a concerted effort to shutter services. For example, the harm reduction kiosks that were removed from Island Health hospitals just a short while back. There's no evidence to support that decision. And there's no evidence that those vending machines were causing harm. However, there was enough of a public outrage, and it was right in the backdrop of a provincial election, that the decision was made to remove them. And that is a policy decision being made because of the desire, the need to get and retain power. It is about people wanting to stay in power, to garner votes, and to not stand behind their policies. And so a lot of this could have been ameliorated by actually consulting people affected by it, by doing really good policy communication and saying, this is what this intervention is intended to accomplish. Not this intervention is going to be a panacea and solve all of our complex social problems. Because decriminalization had a role. It was going to be a part of a broader strategy to stop the deaths. But alone, it was inadequate. And the faults were very apparent. And people really weaponized those faults and used it as an opportunity to stir moral outrage. And that's how we ended up losing a lot of those services.
I'd just like to finish off by saying that, again, a lot of what we're talking about is the kind of on the street impacts of, but most of the people who die from drug overdoses are not. Once again, can you tell us who they are?
And most people who are dying, the face of BC's drug poisoning emergency could be a university student, as we saw with the tragic death of a student at the University of Victoria last year. It could be a young man who works on a construction site who's buying pills on the weekend. It could be business executives using cocaine, but unfortunately their cocaine is laced with fentanyl, because all unregulated drugs are a risk for drug poisoning and death. Or it could be someone who's experiencing homelessness. The vast majority of them are people who are housed, are people who have jobs, or people who rely on them and are actively contributing to society. And that's not to say people who are homeless aren't. That's a harmful narrative too. But we have an image of who's affected by this crisis, and the reality is we are all affected by this crisis. There are certainly groups that are disproportionately impacted. An example of that is the First Nations Health Authority has released a report that has shown that First Nations people in British Columbia make up 3.4% of the population, but 18.9% of all toxic drug poisoning deaths. What that means is if you're First Nation in BC, you're 6.7 times more likely to die by drug poisoning death.
Yeah. And all of that could be averted basically if we had safe supply.
If we had a legally regulated supply, if we treated this as a mass casualty drug poisoning situation, which again, so here's a good example. A couple of years ago, BC drug checkers reported that 3% of all stimulant samples, so cocaine, methamphetamine, that they also tested positive for fentanyl. And 3% might not seem like a big number, but if you could imagine going to your favorite liquor store to buy your bottle of wine, and there was a 3% chance that your bottle of wine also contained fentanyl, if you could imagine what the reaction to that would be from the public, we would not just say, oh, well, don't use alcohol, it's not safe anymore. We would have product recalls. We would have warnings. We would have inspectors coming in and making sure that there's quality control. We would probably have some kind of recourse for the company that produced that supply. We have none of that for unregulated drugs. And there are a significant amount of people, it could be your neighbor, it could be your family member, it could be a friend of yours, who are going to access unregulated drugs. And at a time where 6 British Columbians die every single day from drug poisoning, we need all of the services and we need less of the politics.
It would be nice. It just seems like, to me, what is such a common sense way to go isn't being allowed to happen. But we'll carry on. And thank you very much, Corey, for coming on.
Thank you for having me.
And thanks, everybody, for watching this segment of From Canada's Citizens Forum.